Right, two ticks. I need to be able to see your face, Andy. Hello, everybody. For those who don't know, my name is Torie Robinson, and you probably all guys know that my passion is epileptology and all the lovely things that go with it. But some of the great things that go with it are research, neuroscience. And today I would love to introduce to you Dr. Andy Bagshaw from the University of Birmingham, also on the Scientific Advisory Committee for Epilepsy Research UK, and no doubt a squillion other things, which he's going to tell us about. Andy, tell us about yourself.
Well, I was a physicist once, not anymore. I do brain imaging mainly, working with electrophysiology, trying to combine things, working with any kind of data you can get from the human brain mostly, and trying to make some sense of it, trying to understand what it tells you about the healthy brain, but then also how you can extract something that might tell you a bit more about why a particular brain suffers from seizures, is able to produce seizures, and why not all brains are able to produce seizures.
So what got you into this though?
I guess so I started off with my PhD in nuclear physics, and the problem there is that it's essentially, you don't get nuclear physicists listening to this, do you? I hope.
Well, I don't know. Who knows?
It kind of works. It's done. It kind of, everything is really quite well understood. So then I think this is quite a common route for physicists, that you kind of go into something that's a little bit more meaningful in the real world, that has the potential for a bit more impact in the real world. So then I went into medical physics and into imaging methods specifically for epilepsy, trying to develop different ways of characterizing the brain specifically in the context of epilepsy, and that's kind of continued ever since. And I guess that was about 20 years ago.
Oh my goodness, you must have so many stories to tell us.
I guess I started off, so when the first time I got into brain imaging, there was some unusual things we were doing. So we were developing these methods to image the brain. Basically, when you have EEG electrodes on, but instead of just recording the activity, you inject a bit of current in so that you can basically track blood flow. Mm-hmm. We were developing those methods, and you want something that's reproducible. You want something where you can see whether the method's actually working. So, and these are called phantoms generally. So they're basically a model, a physical model that you make. And this was made out of, well, there's various ones. One was made out of a skull.
A real skull, like an old skull?
A real old skull.
Okay.
And then I spent months doing this. So this kind of, it's still traumatic to me. So this one.
Oh, okay. If it's traumatic, leave it. Like literally traumatic, or.
Then we covered it with the stuff that you if you go to the dentist and they make an imprint of your teeth.
Oh yes.
Covered it with that stuff to represent the scalp tissues, and then we covered it with various items. So at one point I was cutting marrows and squashes and things, because the outer layers of these vegetables, they impede the flow of electricity in a similar way to the way human skin does. So I spent months kind of developing this thing, and it was a bit of a shock to the system. You end up thinking you're doing one thing. You end up thinking, right, I'm working on methods to image the brain, and practically what you're actually doing is going down to the shop and buying a watermelon or a squash or a marrow, and you're then kind of spending your days kind of scraping it out so that it's nice and thin, and then you're sticking it to a skull with this stuff that they use to make molds of teeth.
Wow, it's not exactly glamorous, is it?
I wouldn't say it was glamorous. Not in the normal sense.
And you wouldn't say that that's what one applies one's sort of intellectual ability, passion to do, is to go and use some nice marrow, whatever, and cover.
It isn't. You kind of have to keep the bigger picture in mind. But there is a point to doing this. There is a point to having this model that's going to be reproducible, and that you can kind of just tell whether or not the system you're working on is it able to image what you think it's able to image. It's a definite question of getting through your days by thinking of the bigger picture.
Deep. But I also like that now everyone compare your brain tissue to that of a marrow. I think
exactly.
That's great.
We're not that different.
Oh, cool. So, all right. So everyone, just so you know, when I move my hairs, it's because I'm looking at the pictures that we've already agreed upon, because I'll forget them all otherwise. So, oh yeah, what led you to be at Birmingham University and set up your lab? Because this is your, by everyone, just so you know, Andy has his own la-di-da lab. It's amazing. So tell us about that.
Thank you. Well, it's so I moved here. I mean, I've been in Birmingham now for about 15 years. And before I was in Montreal, and so the sort of the move from Montreal to Birmingham was a bit of a shock to the system as well. Because
I can imagine.
if you get the chance to live there, that's a nice place to live.
Oh.
But it's kind of when I moved here, Birmingham was just getting into brain imaging. So we bought an MRI scanner. We kind of had the facility set up. When I came in, it was a, you know, kind of exciting time to be involved, because there hadn't been those facilities here before, and we've got the chance to really decide how it should go and what it should look like and what the priority should be and kind of what equipment we need, how we're going to use it. And we're next door to a very big hospital, Queen Elizabeth Hospital, which I think is the biggest single site hospital in Europe. I think so. Wow. It's big. It is big. So in terms of kind of having work that can be translated, that can be applicable to patients, it is a good place. Since then, you know, so we've developed the lab since then. We've recently, just last year, we moved into a new building which we need to come and show you, so you can have a wander around. We can show you a video around. That
would be wonderful.
It looks a lot nicer than the old building. You know, the old building was very functional, but now it looks nicer, so that's something to be said for it. But now we've got other facilities. So we've got the MRI scanner, we've got MEG, which is kind of the magnetic equivalent of EEG. So instead of putting electrodes on and measuring the electrical signals of the brain, then you're measuring the magnetic signals of the brain. We've got sleep labs, we've got other labs for EEG. So it's kind of, we've expanded, we've brought in, you know, when you have a bigger facility, you can attract more people to come in, you can get involved with the hospitals more, and you can start different work. So it's grown since then, and I think, you know, I guess I'm well settled here, and it's nice to see that what we started 15 years ago, when it's a bit of a leap into the dark in some respect. You know, if somewhere hasn't had these facilities, hasn't had this kind of work ongoing, it's nice that it has carried on for those 15 years, that the university has invested in the technology and in the area, because I think they do recognise that there's a need to understand the brain. There's a need to understand the brain not only when something's not working as well as you'd like it to do, but partly, I guess, it's about understanding what the brain does normally. Right. You know, outside of any kind of disorder, what's the brain actually doing? How is it doing it? If you understand that, and how that kind of function is represented in the kinds of data that you can actually acquire, because I guess one problem we have in studying the human brain is you need it to be non-invasive. You need people to be able to walk into the facility. Ideally, you know, I mean, for clinical purposes, it can get a little bit more invasive is probably the word we'll stick to. But, you know, for studying, what you need to be able to do is study the intact brain in a person who comes in and they're happy, and they leave and they're happy, and they've been pretty happy all the way through. And the problem is that places some limitations on what you can do. You know, I mean, so we use MRI a lot, we use EEG a lot, and they're okay. You know, I mean, I guess everyone who's had them, there would be, I guess, few people who would choose to have them that much. You know, I mean, the MRI is quite enclosed, it's quite noisy, it's a bit of an unusual place.
Some people get a bit claustrophobic.
They do. But this is the data we've got to work with, and I think, okay, at some point, maybe, you know, 10, 20, 50 years, we'll have even less invasive technologies, and they are, you know, there is work being done to develop the next generation of technologies. But right now, what we have that really allows you to study the human brain are techniques like MRI, like EEG, like MEG, and then it's a question of what do you do with that? What does that data look like? How do you extract information from it, and how do you then use that information to tell you about epilepsy or about anything else that might be going on? I mean, I think in many ways, you know, I think epilepsy is the thing everyone should be working on, and I think lots more people need to get into epilepsy research, not only because of the prevalence of it, but because of how impactful it is on the person with epilepsy, and how, I guess in many ways, how little is understood about what exactly is going on and what needs to be done. And I think there's a lot of scope to help clinicians by providing different types of information.
Thank you. And I
That's
completely...
quite a long-winded answer, wasn't it?
That was, but it was a wonderful answer. Yeah, and we kind of digressed, but feeling your passion is amazing, and that's what we need is people with that passion, like, you know, like yourself. And I said to other people before, it's not even just, it's not a good word, but about helping people with the diagnosis or people who may get the diagnosis. It's also about our families, and it's about society overall, because it doesn't just affect us, you know, it can scare other people and they don't know what's going on. So you have you're going down the street and people think you're drunk, and no, you're not, you're having a seizure or whatever. I was arrested once because somebody thought that I was drunk, and I was banged up overnight. And so all these different things, and just listening to you, it makes me think of how I bet you find out or retrieve loads of data that can actually help people to understand things other than epilepsy, I imagine, and the comorbidities that go with it too. Is that right?
Yeah, so I mean, I guess a lot of the focus of what we're doing at the minute is down that line. So I've got a big interest in sleep as well. I won't start off on sleep in the same way, but I think what we're really interested in at the minute is a lot of the interactions between sleep and epilepsy.
Or lack thereof, in my case.
Yeah.
But yeah.
This is the thing. I mean, and so we've got a project ongoing at the minute looking at sleep in children with epilepsy, on the basis of kind of wondering whether or not some of the difficulties that are attributed to epilepsy might be the outcome of disrupted sleep and poor sleep patterns. And if they were, and I think there's certainly evidence that people with epilepsy generally, children with epilepsy, have poorer sleep than their peers. And anyone who has poor sleep is going to have an impact in their daytime functioning. You know, whether that's their ability to concentrate and their academic performance is likely to be impacted, but also their mental health. So
thank you. Yes,
you take someone and sleep deprive them, they will feel more depressed. Their interaction with emotional stimuli will change, so they will perceive negative stimuli as more negative than they would have done if they were well rested. Now, if you take that kind of context where we've got reduced ability to perform everyday tasks, you know, impact on cognition, impact on mental health, and then you take a cohort of people with epilepsy who are known to have poor quality sleep, then that is something that needs to be understood. I mean, it might, in many ways, it might not be a major impact. It might be that the epilepsy itself is the major impact. But I think the disruption to sleep that we're seeing there needs to be understood more, and the extent to which that disruption to sleep really feeds forward and has an impact on people's quality of life. If we could understand that a bit more, then, you know, taking this broader view that epilepsy is not just about seizures, it's about all of these other factors that have an impact, and the general reduction in quality of life. And if some of that is down to disrupted sleep, we can probably do something about that.
Oh, that would be so amazing, because I think people without epilepsy can really get where we're coming from here. Like if they have a bad night's sleep, gosh, you can be in a right strop the next day, you know, you feel less productive. Oh, so many things. And or you just like, well, don't want to like interact with too many humans. Oh God, it's so annoying. I just want to go to bed. And then there's the additional fact that many of us will have more seizures if we don't get quality sleep, of course.
No, so
and then and then we're stuck in this circle. And if you're depressed, you often, although you can be really exhausted, it can be hard to get to sleep. Yes. And then there's that impact of the anti-epileptic drugs, which can also affect your ability to... Exactly. So, I mean, I'm getting the impression that data collected from your research will be able to sort of help us on all levels at some point, fingers crossed, in the future.
That would be the hope. That would be the hope. So we're really trying to understand what aspect of sleep is most disrupted and what it is disrupted by. You know, is it... Obviously, some people are going to have more seizures at night, and that's likely to disrupt their sleep patterns. In the same way, you take anyone and you wake them up periodically through the night.
Yeah.
The next day, it's not going to go well. So it might be kind of the behavioural impact of being woken up and having lighter sleep throughout the night. It might be more to do with the more precise electrophysiology of the discharges and the activity that is involved in epilepsy, whether that is to do with seizures or whether it's interictal discharges, so the smaller discharges that might be ongoing all the time.
Right.
They are likely to be disrupting the networks in the brain that are responsible for sleep and for the processes that go on during sleep to help you feel the next day like you've had a good night's sleep. So we really kind of need to tease that apart, which aspect is really the problem.
Yeah, and the people that you study, are they people with all different types of epilepsies, or and people of all ages, people of all sort of levels of intellect, etc.? How do you work?
At the minute, we're focusing on children. So we're working with Birmingham Children's Hospital and Worcester Royal primarily. The focus there, and that is, so that's all ages of children from about, so I think our minimum is about 4 years of age.
Mm-hmm.
We're using the clinical assessment, the clinical data that a lot of children will go in and have a nap study.
Okay.
So again, we're trying to fit in as much as possible with the way in which people are diagnosed and tested routinely, and then try to extract more out of that.
Uh-huh.
So we're basically recruiting anyone at the minute who goes in to those two hospitals for any reason, because when people go in for the test, when they go in for the nap study,
yeah,
which is the point at which we want to recruit them, the diagnosis hasn't been given, so they don't know if they've got epilepsy. We don't know.
Exciting.
No one knows whether they've got epilepsy.
Yeah.
So we recruit people, and we need a control group to compare against as well. So that will be helpful. So we end up with a mixed sample of people with epilepsy, people without epilepsy, different types of epilepsies. We do have a focus on Rylandic epilepsy,
mm-hmm.
which is a childhood epilepsy that is unusual, I guess, in the sense that often it does rectify itself. So as a child gets older, then it's one of these that they may grow out of the epilepsy. So in some ways, and sometimes when I say that we're interested in Rylandic epilepsy, people say, well, it's not the most severe, and you know, it's why are you focusing on that? Well, why not focus on the more severe? I think it's for the understanding of what we're trying to look at the minute in terms of the interaction with sleep. The fact that it rectifies itself is interesting.
Right.
The fact that it doesn't have a huge number of seizures is interesting, because that means mm-hmm. that if we have disruptions to sleep, they're probably not because of seizures, but they can be because of more behavioural issues around how a family with a child with epilepsy interacts with that child, and sometimes there can be sort of coping mechanisms that the family sets up that might not help to get a good night's sleep. So right. in the way that, you know, anyone with a child, they're worried about how their child is sleeping, and they might go in and just check on them and check that everything's okay. If you're worried about your child having a seizure, then you probably do that a little bit more, and that becomes potentially disruptive to your own sleep and potentially disruptive to the child's sleep and their ability to self-soothe. So we've got this idea that with Rylandic epilepsy, if we don't have the seizures disrupting the sleep, it might be a little bit cleaner from the point of view of understanding these interactions. I think in the longer term, one of the things I'd really like to get to grips with is why that epilepsy goes away in the majority of people.
Right, that when you mentioned that before, I was like, gosh, that sounds so exciting. If you can find out why that goes away and what the process is, then perhaps, I don't know, maybe I'm getting carried away with myself, but would you be able to, in the future, figure out how to apply that to other different types of epilepsies, right? Who knows?
This is the thing, you don't know, do you? I mean, you've got a type of epilepsy there that suddenly, well, you know, over a reasonably short period through adolescence normally, will kind of just stop producing seizures. Yeah. And one of the things we're looking at, so we have the EEG data that's recorded during this NAP study. And one of the ways we're looking at that is to look at brain networks extracted from the EEG data. And I guess kind of the idea would be that maybe as the children get older, the configuration of the brain network that is there and is able to produce seizures, there's an interaction and there's a reorganization of the brain as the child develops. I mean, you know, there's a lot of changes that happen to the brain from the age of, you know, birth to 18. This is a period when the brain changes hugely, and presumably, and I'm not sure there's a huge amount of evidence for this yet, but presumably some of these changes in brain networks as a result of development interact with the brain networks that are capable of producing seizures and kind of cancel them out in some way.
Oh, amazing.
I mean, from our point of view, I guess it could be genetic, it could be completely different, it could be
who knows.
But I think from the sort of approach that we take and the sort of data that we work with, that would be the kind of way we're looking at it.
And then even if it is different changes that occur genetically, that doesn't mean that those cannot be replicated necessarily in other people, because there is so much research being done into genetics, right?
Yes.
So
I think that's one of the it's fascinating, but it makes it very difficult with epilepsy, is to understand the links between different scales. So we kind of work at the whole brain level most of the time, all kind of brain regions, kind of macroscopic data. How does that relate to individual neurons? How does that relate to ion channels and the things that are on individual neurons? How does it relate to the genetic codes that kind of organize that brain as a whole and give it susceptibilities in certain directions? So all of the time we've got this multi-level problem that we really need to understand how these different levels of data interact with each other. And like you say, I mean, even if if everything has an underlying genetic basis, at some point that represents itself within the data that we have to work with. I guess we just need to figure out a little bit more about why and how.
Wow. And this is why we need so many people working in the sphere of epilepsy and epilepsy research, because there are just so many different bits to work on, and then communication within those teams needs to occur. So that, it's just incredible. But just like listening to you talk and seeing your face, you're just like so passionate, and this is what we need more of. And we need more people with epilepsy, and families, and indeed, do you know what, schools, and the general public, to just realize how, like, this is so cool, this is so interesting. We need to all know more about exactly what you're doing, and manage expectations, people to recognize that, you know, these types of research take a long time, because you have to be so, I was going to use a rude word there, but I won't, but just like so precise and in what you do, and check things again. You can't make any errors. And that takes a lot of time and a lot of money, because people have to be paid for what they do. But long term, I just think, it's even great for the economy. If people don't really care about fellow Homo sapiens, this is great for the economy, and not just with people being employed, but about getting more people like myself into work, about having less family members negatively affected by people with epilepsy, whether they have to be carers or you know, whether they are affected with depression, anxiety about their children, all these type of things. I think investment into the work that you're doing is it benefits every person in the planet, quite frankly.
Yeah, I think, yeah, I would agree, but then I probably would agree. I'm probably not going to disagree with that, am I? I think that kind of, if you look at the impacts of having epilepsy, not only in terms of seizures, but in terms of those things like the mental health aspect, like even the disrupted sleep and the impact that will have on an individual.
Yeah, the exhaustion from the drugs we have to take.
Yes.
The impacts of that on our mental health and the way that we interact with other people, you know, it's just one thing after another. And yeah, but if more,
no, I think in the longer run, I think that would be the hope, that, you know, you'd be able to understand why these things actually occur. You know, why? I mean, in a way, it isn't a given that having epilepsy would lead you to be at higher risk for depression.
Of course.
Or to be at higher risk for having sleep problems. And parasomnias, you know, sleepwalking, sleep talking, people with epilepsy are at higher risk of those kind of problems as well. That doesn't have to be the case. It's not like, well, that's so obvious, we don't need to understand why. I think if we can understand why, then maybe we've made a bit of progress to starting to think, well, okay, this is what we need to do in order to reduce those risks, so that having epilepsy becomes less of a burden, becomes something that is that bit more straightforward to cope with. And in the longer run, we can work out how to control those brain networks and stop them going into the seizures that are the main problem.
And just having more people like myself, just hearing you talk and hearing about the work that you're doing and using all your brilliant lingo, which for most of us lay members just goes straight over our heads.
Oh dear.
Because no, you're good. I'm getting a little bit better, although as you probably empathise with, learning takes a little bit longer for some of us than others. But I created an epilepsy glossary on the website so that patients can say, do you know what, mate? No idea what that flipping means. Like, let's look it up.
Well, if there's anything I've just gone off on that made right now you're thinking made no sense at all, feel free to ask.
Oh, well, do you know what one was? Ion channels. That was from a way back. Tell everyone what that is.
So
they are.
So the brain's made up of neurons, essentially, which are one type of cell that's within the brain. There's lots of other types of cell, but I guess in terms of kind of communicating between brain regions and kind of doing the processing, it's generally the neurons that are there doing that job. And they send electrical pulses along, so they have long stringy bits that allow them to communicate with different brain regions, and they send electrical pulses along that. And the way in which those electrical pulses are controlled to a large extent is by opening up these gates essentially within the cell and letting in different types of ions, which are, you know, different charged particles, which will cause that electrical pulse to actually occur. Now you can imagine if you've got this neuron and all of its channels are open, all of its gates are open, everything's flooding in, that means that it's got a higher likelihood of actually firing. And if you think of epilepsy as a kind of an uncontrolled firing of individual brain cells, too much synchronization between different brain cells, so that if one fires, it's unnecessarily likely that another one fires. At some level, that's all controlled by the ability of those individual cells to control what comes into them and what goes out of them. And that's kind of where the ion channels fit.
I think that's a really good explanation. Really good explanation. Okay. And I did have another question, but I've forgotten it now. So but maybe I'll think about it later. People will get used to me forgetting stuff. So do you know what? We've completely digressed from our questions, which is wonderful. Yes, I think it's like just an authentic conversation, which is great. And do you know, it's also great because so many people, understandably, but unfortunately, can be a bit intimidated by people who are researchers, scientists, doctors and stuff like that. But guess what? These are really nice, like, people. You're normal. Well, what is normal? But you know, you're just another fellow human, and you're doing it for us and the wider community as a population. And you know, this is really cool stuff. So everyone, try not to feel so intimidated by these people, please.
I think I think in general we're able to hold a conversation.
Yeah.
Not always, you know, there's some outliers to that, but mostly I think, you know, there's the ability to hold a conversation. We're not too bad.
Well, and also I do notice, although maybe I'm quite fortunate in knowing people like yourself, Andy, but you know, the Dunning-Kruger effect, you know, you guys are very knowledgeable, so you get to a certain sort of level of knowledge in your specialization, and then you realize how much you really don't know. Yes. And I think that really positively impacts a person in terms of whether they would be arrogant or not. You know, you guys realize, like, wow, there is still so much to learn, and you can't see the end of that. You know, it's just gonna, just how effectively unknowledgeable you are, but all of us are. And that's what everyone needs to know. And like, we have specialists in the field, of course, such as yourself, but there's a limit to what everybody can know, and you have to share all that knowledge and get, I think, input from lots of different people. Do you agree?
Definitely. I mean, I don't think you can overstate how little we know about how the brain works. Personally, I mean, I think, and that's one of the problems with any kind of psychiatric, psychological, neurological disorder, that if you don't really understand how the brain works at all, then it's very difficult to then understand what bit of it is producing this behavior that you don't want, or is unhelpful to people. And I think, yeah, I think we again are making progress, and I think there are now, I mean, in many ways, although the kind of tools we work with MRI and EEG and MEG, they're a bit weird and they're a bit unpleasant, and they're very limited in many ways in terms of the information they can provide about the brain. But in some way, you shouldn't, you know, you can tell what's happening inside a person's brain without them, you know, without needing to open them up, without sticking electrodes in.
That's ideal. Yeah,
it's difficult data, and it's complicated, and I think, you know, fundamental understanding of in many ways what the brain is even there for and what it's actually supposed to be doing, that's you know, that's still ongoing. But I think there's progress being made, and I think, you know, you can start to see patterns emerging in the type of data we work with of really sort of fairly robust and reproducible changes that you would expect to see in the brain of someone who has epilepsy, or someone who has depression, or someone who has a sleep disorder. You know, there are these changes that you can start to work with, and they're a starting point. And then, you know, like you say, we need to be talking to people with different specialisms. And I think one thing that's obviously extremely important about what you do is we need to be talking to the people who actually live with the thing that we're trying to understand, because otherwise there's a tendency to kind of, you know, we might think it's very important to do this or to understand this, and it may not be the problem. You know, it may not be the problem that anyone really is asking to be solved.
yeah,
and then
but
wasted 10 years of your life trying to do something, you know, that is really not the thing that you should be focusing on.
But you know what you did, as you were saying earlier, like you're focusing on Rylandic epilepsy, but you were able to explain to me that actually it's not just about Rylandic epilepsy. It's about how a lot of people with Rylandic epilepsy grow out of it. And why does that happen? And finding that out can help people with any type of epilepsy at all. And so just getting us lot to understand that makes us realize, oh, okay, so it's not just about young people with Rylandic epilepsy. In fact, it's actually about everyone. And that's why it's so valuable, I think. And it can normally be said, I think, for many types of neurological research, because we've all supposedly got brains, and, you know, there's a balance, right? We have what we'd like to be focused on, but we also need to recognize that everything affects everything in that squishy stuff.
Yes. Well, this is the thing. I mean, I think, you know, even within epilepsy research, we need to be open to what's happening outside, not only for other neurological problems, but also what's happening in the general field of understanding how the brain is set up. You know, we're too focused on saying, well, we need to work on epilepsy, we need to understand epilepsy, doing that in isolation of all the work that's being done to fundamentally understand what the brain is doing, and to fundamentally understand from the kind of data we work with, how should we be analysing this data, what should we be doing with it, and then taking, you know, essentially taking all this stuff these clever people do when they're trying to understand other stuff, and saying, well, okay, now we'll apply it to epilepsy, now we'll use what has been developed, and we'll say, well, can that tell us something about epilepsy? And then it's a question of, I guess, not being too specific about only some types of epilepsy. You know, historically, I guess some types of epilepsy have been studied more than others. I guess historically, the more simple type of epilepsies that maybe don't have other issues coming along with them have been studied. And I think it's important to be able to generalize and really apply it to anybody going into an epilepsy clinic. You know, you want to have something that you'll be able to provide a degree of understanding of the type of epilepsy that they're living with.
Yeah, I confess I do get a bit, and maybe this is unfounded and just on based on my own ignorance, but because there are so many people in research, although not enough, as we've previously spoken of, around the world, I do sometimes wonder if we've got a bit of duplication going on, and I wonder if there is also, unfortunately, a bit of a lack of working together and sharing data. I wonder how much time we could save if everyone kind of just shared a bit more. Do you know what I mean?
That is the direction that the field is going. I mean, you know, it's for epilepsy, it's probably early days. There are some fields where it's a little bit more developed, but I mean, there's papers coming out now of imaging data that's been shared from across the world, and so you've now suddenly got
Brilliant.
cohorts of, I can't remember how many it was, it's sort of thousands. You know, you're not talking about, well, I scanned a few people from the Queen Elizabeth Hospital and here's my 20 people. You've got people from around the world pooling their data. And
Wonderful.
that is direct. I mean, you're completely right. That's the direction it needs to go in, and I think maybe somewhat slowly, but I think the field is recognizing that. And I think, you know, the more we can have these multi-center studies, the more we can say, well, okay, I've got the ability to scan 20 people, or I've got the ability to do EEG on 20 people. But if you take that for labs around the world, that gives you a much more nuanced understanding of what's going on. And then maybe, I think partly that also leads you to be more willing to take anybody who comes in and not be too restrictive about the type of epilepsy they have, because if you've got that bigger cohort, maybe you can deal more with the complexity that you have. So it's not, well, okay, it's all going to be about temporal lobe epilepsy, it's only going to be Rylandic epilepsy, and we're not having anyone with any kind of mental health problem, we're not having anyone with any other issue going on at all. You know, it's only going to be this certain type of epilepsy and nothing else. Partly, I think that has always been driven by the fact that you only really have quite small cohorts, and so you want them to be relatively clean, because otherwise, you know, and clean in the sense of homogeneous. You want to be able to be sure that people are relatively similar, and you maybe don't have the ability to take into account individual differences that you know are there. So you kind of say, well, okay, I'm going to try and reduce those at the point of recruitment. Whereas when you get up to 1,000 people, 2,000 people, whatever it might be, and you've got all this other data, and you know, okay, maybe you know for each person what their burden of depression is, what their burden of anxiety is, whatever else it might be, things that you know are going to be important. What's the variability in their sleep patterns? Though, you know, all of these things that you know are going to be important, when you've got those bigger cohorts, because you've been more collaborative and these big networks have been set up, maybe you can start to understand a little bit more about the interactions between epilepsy itself and different types of epilepsy and these other issues, rather than just pretending they're not there.
Yeah, see, and this is just like so exciting, and it makes me think of how I've got all these thoughts going through my mind. Don't get me too excited, by the way. Sometimes, I kid you not, right? Post-surgery, I've started having auras when I go to neuroscience conferences and stuff. So I just get so intellectually stimulated to my limited amount that I just like, oh my God, no, please. And it hasn't gone any further, but it's just so funny how that can happen. And it's so different for everyone. God can bring on a seizure, you know. Anyway, I was going to say, I work with a lot of people from around the world, the different continents we have on our little planet. And what I also find really interesting is the impact of different cultures on people with epilepsy. I could go on like further access to drugs and stuff like that, but also genetics. And because in many developed countries, at least, we have the majority of people involved in research are white. And I'm really interested to find out, well, first of all, encourage people who aren't white to get involved. That would be brilliant too. And then I think we might be able to more effectively help people in other countries, like on the biggest continent of Earth, parts of Africa, you know, wouldn't that be wonderful? I really think, you know, and I'm wondering how we can appeal to people from ethnic minorities a bit more. What do you think?
I think it's an important problem. I mean, I think it is, you know, you look at across the board, it tends to be the case, and then a lot of participants, you know, an overwhelming number of participants will be white, that you're not really representing the diversity even within your own community. I mean, you know, obviously in Birmingham, we've got a really diverse community.
Yeah, same here in London, yeah.
What we're trying to do, I guess, is reach out as much as possible to have a representation of the place where we live in the participants who come into the centre. It's not straightforward. I mean, we have to find better ways, and I guess this is what you're doing is one way of doing that, but getting better ways of having interactions between scientific establishments generally and the community, because we are, I think, a lot of the time really quite cut off.
Yeah,
we need to get out there more and make it clear that this is work that's going on. These are you know, the kinds of people we need to come in. This is why it's important that we have a representative set of people coming in for our own community, and that will hopefully allow us to be able to generalize more around the world as well.
Yeah, because there are going to be some differences, aren't there? Like some, for instance, I was reading this article on sickle cell disease, which in, you know, sub-Saharan Africa is really common. And so if there's, for instance, that genetic difference, well, there might be other genetic differences around the world between ethnicities. So we need to figure out what those are. And so therefore how we can more effectively treat people around the world, right?
Well, this is the thing. I mean, you need to be able to take the person as an individual. And they are an individual, and they have different susceptibilities to different issues, and part of that is going to be down to where they've come from and you know, their genetic background, and that will interact with everything else that's going on. And if we don't understand that, then essentially you're letting down a lot of people around the world.
Yeah, a few billion.
Just a few.
Not funny, sorry.
But this is the thing. I mean, you're limiting your ability to really have a proper idea of what you mean by epilepsy or whatever else you might be interested in. But really, what is the diversity of that as an issue?
Yep.
And how do you deal with that? And you know, someone comes in, someone has seizures, someone has epilepsy. What do we need to take into account? And what will, from our point of view with the imaging, the electrophysiology, are there other issues that we might need to take into account in order to properly interpret the data? And in some ways, you know, I guess when we're working with looking at the impact of sleep problems, in many ways you could say that everyone coming in for imaging, it would be a good idea if you'd taken into account their sleep patterns on the previous night, but maybe over the last couple of weeks, maybe historically.
Like during Ramadan or something like that, then people could be, exactly. Absolutely. So interesting. So if anybody is listening to this of any ethnicity and you've got any ideas how we can more effectively recruit different people, please let us know, right? That would be great. Definitely. Need all these ideas. Okay, cool. Again, we digress, but this is really cool. Oh yes. So what are the current? Well, you've told us about your current studies actually, and oh yeah. So what's going to happen over the next 1 to 5 years? How are you going to change our world?
In
your team. Sorry.
In my crystal ball.
Yeah. That would be it. Yeah. Well, that's an exciting thing about science and research. You just don't know what's around the corner, right?
No, that's right. That's the easy question. Who knows?
Yeah.
I think the direction that that I'd hope it went towards was really based around this individualization and this understanding of what aspects of that person as an individual, whether it is racial background, whether it's sleep patterns, whether it's aspects of mental health, whatever it might be, we need to understand all of those issues and how they impact on the data that we're getting. Let's say we're particularly interested in epilepsy, we're interested in using MRI, we're interested in using EEG as part of the diagnostic process, so that a clinician can know, you know, what is the best path for this individual patient.
Yeah.
But for that individual patient, there may be various other things going on that mean that the path should be slightly different. You know, we need to understand, because they affect the data. They might affect the EEG data that you're getting, and that might affect your interpretation of that person's epilepsy, because of things that maybe are not completely epilepsy related,
right,
but are part of that individual.
And also, like, well, I'm not quite sure what I'm supposed to call it at the moment, like pseudo seizures or non-epileptic seizures. Do you come across that quite a bit too?
Yes, and I think that's an interesting, I mean, in many ways, so we're looking at kind of particularly seizures, I guess, that occur out of sleep.
So they can't really have those during sleep, or can they?
You can do. And
oh, cool. Well, not.
But three-way split between epileptic seizures, and so something weird is happening out of sleep. It could be epilepsy. It could be a sleep disorder. It could be, you know, a parasomnia or something where someone's just having this unusual behaviour out of sleep. Yeah. It could be a dissociative disorder or some other kind of non-epileptic attack. And I think, you know, we need to be able to differentiate those. And a lot of the time it can be quite difficult, especially, I mean, the person themselves, they almost certainly don't know what they're doing in any of those situations. They don't know what their actions were. They couldn't probably report to you exactly what they did. And then we need to be able to look at EEG data or whatever kinds of, and maybe wearables, you know, kind of, there are a lot of wearables now, including Wearable Eeg, where people can have EEG in their home environment relatively straightforwardly, and there's certainly a lot of developments in the technology which might mean that, you know, every night when you go to sleep, you stick a couple of EEG electrodes on, you know, like just a couple of sticking plasters, stick them on there. It's monitored through your mobile phone.
There are so many of these things out there, aren't there?
If something weird is happening that you're not quite sure about, and then the kind of data at the minute, in terms of sort of EEG linked with video, the only way of getting that at the minute really is to bring someone into the hospital. But,
well, you say that, but what's really inside to interrupt, but what's interesting when people go for like video telemetry or video EEG is, and this happened to me, I'm just like so chilled out, man, in the hospital. I can't have a seizure. That's happened to me. Have you heard of it?
It was going the other way.
No, well, I guess for some people, but no, loads and loads of us don't. So we go into hospital and it's like, and I guess it depends on your background too, but I used to like be in this really stressful corporate environment. I'm like, mate, peace, man, this is great. And then I could start getting a bit stressed, like, it's not happening. And so completely unsuccessful. The only time you want a seizure. So then a few months later, I had to come back in. And luckily, I was so stressed that I had a seizure. But this is really common for us lot. Yeah, interesting, right?
Well, I mean, also, having seen a lot of video EEG recordings over the years, and you're kind of, the video part of it, people look so bored most of the time.
Oh, mate, yeah.
You're just sitting in bed.
Please at least give us like a telly or something. Yeah.
So, I mean, I guess it's better these days, hopefully, because at least maybe you can bring your tablet in or something. You know,
exactly, yes.
It's a little bit more entertainment.
If you've got good Wi-Fi or just everyone prepare before you go in, download it, yeah.
Hospitals are not necessarily known for their good Wi-Fi for patients, as a rule. But maybe you can get away from needing to bring people in for those kinds of recordings, because you can do them at home, and their normal level of stress, which, you know, could be quite a good thing. Maybe they don't need to be tied to the bed in the same way, because, you know, they can go about doing their normal business. Their sleep will be much more normal. You know, you bring someone into the hospital, there's almost certainly they won't sleep in the same way that they'll sleep at home.
Those beds are awful as well. Ugh. I swear they make them uncomfortable on purpose.
Yeah. I think the hospitals in general are not set up for producing a good night's sleep. I don't know why, because given the importance of sleep for the recuperative process for whatever you're in hospital for, they don't necessarily seem to be set up to get you sleeping as well as you could.
Do you know what? After surgery, I couldn't think that much, but there was this poor girl who'd had, I think she had some frontal lobe surgery, and the poor girl was off her face coming in. She kept wandering off into our ward, just like, what? And it was just in the middle of the night. And I'm just like being utterly sarcastic in my head, thinking, guys, you've just tried to stop my seizures. Do you want me to have one right now? Because I can't sleep, you know? Gotta laugh, it's not funny, but you know.
No, but yeah.
But they do what they can do. I love the NHS, so.
Yes, no, this is the thing.
Love.
I mean, obviously, everyone's working under a lot of constraints, and it's not easy to set up a place for good sleeping. So there's a reason, and you have to monitor people, and periodically you might need to wake them up to make sure they're okay, particularly, I guess, post-surgically. But if for those kind of cases where maybe it's not post-surgical, so that you don't really need to be in the hospital as such. If you could get to the stage where some of this data, some of this information that would be useful to know what's happening with someone's epilepsy, if that could be recorded at home.
Cool.
I don't know, it seems to me, I don't know, what do you think? I mean, it seems to me that would be a good thing. I mean, maybe I'm going off down one. I think that's a great thing.
No, I do think it's I think it's got its pros and cons. I think it's great for people because it can be a lot less stressful. So a lot of people get really anxious in the hospital, and especially people with like, and I'm generalizing here, everyone, but a lot of people I know with autism, for instance, don't like going out much or being surrounded by people, and often don't like having these electrodes put on their head. Well, a lot of people who don't have autism don't like it that much as well, right? Yeah. But, and also, this sounds really backwards, but you know what I was just saying about how I found hospitals so relaxing when I'm having EEG? Well, that might not be the case at home. It depends upon a person's home environment. You just don't know.
Yes.
And also, personally, I've only had it at home, well, I think once, it might be more, but I can't remember. And yeah, probably a couple of times. Anyway, and I was just like getting worried that I was going to knock the electrodes off or something. And so the worry is probably a good thing. So I might be more likely to have a seizure, but it's not a good thing if, well, I do knock it off somehow. And that stops, the seizure from being recorded. But from the majority of people I speak to, they tend to prefer it at home. I'm just strange. Yeah. I prefer it in the hospital.
I think partly though, I think to me, it's a question partly about the developments in the technology as well, so that the electrodes basically can't be knocked off. They're not like normal electrodes, because at the minute, I think when you have it at home, it would be a pretty standard EEG, and there'd be this sort of relatively standard electrodes. Whereas if you get to the stage, which is now the case, where things are a little
less
bit
scratchy,
they're less head scratchy, you know. Maybe you can get enough information from electrodes that don't need to be under the hair, so you don't need to sort of mess that up. And maybe, I mean, there are now electrodes where literally they're just more like a sticking plaster, and you can put them there, you can put them behind the ear, so you can get maybe not quite the same level of data, but you don't need to be so worried about pulling them off. I mean, I don't know, whenever I've had EEG, I don't particularly find it comfortable for any length of time with a full.
It's good you've been having them as well. So just so everyone knows, you empathise with that good look. It's such a good look, man. Yeah, well, that's something that people do get worried about. Like, they go, oh, I look rough. And then, I'm strange. I took photos and put it on and post. Like, look at me, darling. Put it on social media because I think it's amazing. Because I do think of, like, because I was diagnosed in 1991, showing my age, and back then there wasn't a lot that one could do. Like, you guys have come so far. Yes, I had an EEG, which showed no abnormalities at all. 20 minutes, in the hospital happens for a lot of us, like, showed nothing. And I had an MRI, but I don't know how good that was at the time, and I was too little. I can't remember what the results were. But now you guys are doing so much more, and I just think, wow, what a time for us to be. Having said that, like, we need to encourage, I am going to go into politics here. We need to encourage government to invest more, because as things are at the moment, we're all going through troubling times, and priorities are being made, rightly or wrongly, about where the funding goes. And a lot of money which would have gone into research is now not happening. And this is an issue. And I do think that, since there are, it's not the official statistic out there, but, well, I always say that our human population, because we won't stop breeding, is nearly 8 billion. There's probably about 80 million of us, if not more, people who aren't diagnosed yet. Let's use our numbers, get together and say, do you know what? This is a priority. epilepsy is a priority. Epilepsy research and treatment is a priority. I think we all need to get together and say that.
No, I think for the number of people who have epilepsy, and for the nature of what those people are having to live with, it's massively underfunded. I mean, I think certainly from the research point of view, but I think clinically, there's a lot of scope for having more epilepsy services, offering different types of service, and just basically improving the services. And I know, you know, the NHS is working under a lot of pressure.
Hence, we need to provide more funding for it. You know, I've spoken to so many people who would say, I would definitely give, you know, another percentage of my income if it was going to go to the NHS. And I'm certainly included in that. I'd give another 5% if I knew it was going to go and help people, and train more, yes, people like yourself in research, but also more epileptologists, more people who specialize, because a neurologist in general, as brilliant as they are, if epilepsy is so specialist, you know, so if you've got somebody with refractory epilepsy, uncontrolled seizures, then we need to see a specialist. And I had refractory epilepsy, wasn't even considered for surgery until it was 22 years, because I'd been in this, hadn't been in London then, and I was just going along and being told all these things, well, you know, take your pills, remember to take your pills, and it's not as simple as that. And there was such lack of empathy, and it was like, well, and I was seeing a neurologist once a year, despite how I was at high risk of SUDEP, and I didn't even know about SUDEP back then. And so it's things like that which we need to have the money to educate people about, both in the medical profession and as public, I think.
Yes, I mean, I think there were not enough epileptologists around, essentially. And like you say, it is such a specialism. It's such a complicated issue to have to deal with, that you want as many people as possible, as many clinicians as possible, who really, that's what they do. They really understand epilepsy, because epilepsy is not straightforward to understand. You know,
that's why I love Queen Square UCL. They saved my life. Amazing, because they specialize in neurology, and epilepsy. Yeah, and then people like Arjun Sen, he's amazing, and Rohit Shankar. And by the way, these two guys should be like really complimented, because I barely remember names. So, but this is the impact they made on me. Like, they're amazing, you know, and like yourself. So I just think this is what we need, more people like you, like them.
And I think your issue of waiting that long before surgery was considered. I mean, I think, again, not as a clinician, this is probably not my place to
say it,
but it's a problem, isn't it? I mean, it is a problem. I think there's a lot of data out there that, okay, I guess no one really wants to go down the surgical route if they don't have to. You know, it's a big issue. It's a big thing to really consider, but it can be very successful. It can make a huge difference, and I think at the minute it is often years and years before it is considered in people for whom clearly the medication is not doing the job you'd like it to do.
Right, and also I think us lot, patients and families, need to be aware that we won't even be considered for surgery if it's not potentially of benefit overall. And then even in the process of being assessed, and majority of people aren't yet suitable, if you get to that end point and they say, do you know what, you would benefit from surgery, but these are the pros, the potential cons, these are the risks, then you can make that decision. But that would not even be proposed to you if your neurologist thought that this could be of benefit for you, or this epileptologist thought that this could really go in your favor. And we need to recognize that, you know, if you have uncontrolled seizures, there is that greater risk of SUDEP, especially if you have tonic-clonic seizures, or, you know, just injury from like falling on a railway line like I did, and stuff like this. Yeah, I know, what a drama queen. And I tell you what, my sarcasm just got so awful because of epilepsy, because if you don't laugh, you just cry all the time. And yeah, and I think just awareness of risks, but pros of epilepsy overall, knowing that stuff is of real benefit to us. And then even if you aren't suitable for surgery and you have uncontrolled seizures, at least then you're empowered with that knowledge, and that is great for your mental health And then that is consequently often really good for reducing your risk of a seizure. If you can just calm down a little bit. Easy for me to say, I know, really easy for me to say, and it doesn't work like that for everyone. But I just find meeting people like yourself, learning more about it, that is just so good, just to give me that gooey feeling inside and go, oh, okay, and good stuff is going on for other people, and we together can help support that. I need a bucket to vomit in now, that was but right, okay, anyway, right, so what I think I can kind of guess what you might say, but what drives you with your work, and why do you come into work every day?
It's complicated, isn't it? I mean, I think the topic is complicated. That's what's interesting. I think you're working with something that is intrinsically very difficult to understand, but for which there's clearly a lot of benefit if you could understand it. So I think, if we really did understand more about how the brain worked fundamentally, if we understood more about how we could use the kind of brain imaging signals that we can work with to extract specific information in particular types of brain disorder, and particularly in epilepsy, then you could make a lot of difference to a lot of people. This is not niche sort of stuff, is it?
People think it is, but it's really not, because epilepsy doesn't just affect people who only have epilepsy. It affects so many people with Down syndrome, so many people with dementia, so many people with autism, and therefore impacts even more than a greater number than I suggested before. It's so important for you to, so I guess it's your knowledge that makes you think, wow, this is really worth doing. Is that right?
It needs doing, doesn't it? I mean, it's I think when again, your previous point about the level of understanding of where we are about how the brain works and what we should do about it, that's not really good, is it? We should be able to do a bit better than that. We should be able to push this forward, and there is such pressing need to do it, and it can't come quickly enough. There's people living with epilepsy every day, and like you say, if their seizures can't be controlled medically, and even if they can, anti-epileptic medications are difficult. You would know better than me, but have always seemed to me they're not paracetamol. They're not they're not easy medications to get on with. The more we understand about why the brain produces seizures, then hopefully the better the treatment gets. So hopefully the more widespread the treatment gets, not only in this country, but again around the world. Fine, we're going to be studying people in this country. We're maybe linking up with other countries for which there's lots of access to MRI. So, we may be talking about the richer countries around the world could be studying epilepsy in the way that we are. But everyone can benefit. If we can understand what's going on, then potentially we have the ability to help improve the medications, to help improve the surgical outcomes, to understand how epilepsy is interacting with other issues, and how that complicates matters and how you should deal with that. There's a lot of benefit. There's a lot of reason to get out of bed. It makes you think, actually, when you put it like that, I probably shouldn't be going to bed. Actually, no.
Come on, anyone could have and also, you don't go to bed, anyone can have a flipping seizure, so please don't. Now, if people want to contact you or check out your work, where do they go? I will provide URL to your website if you're cool with that. But is that the right thing?
Yes, that's probably the easiest thing. So we're available through the Centre for Human Brain Health, so you could see what we do more broadly within the centre as well. And then my group website, the Multimodal Integration Group. MIG, it's like a Soviet era fighter plane. Analogy.
Is it?
Yeah, it is. Yeah. I don't think that helps. But nonetheless, I
love aircraft. I wanted to be a pilot when I was little, but kind of couldn't, so so that's the nearest I'll come to. I like that. MIG.
There you go.
Yeah.
So I think anything like that, there's stuff out there, and if anyone's got any questions, got any issues, I think we're going to have a focus group soon, hopefully. Particularly, we want to understand a little bit more. So I've only worked with children with epilepsy for the last couple of years, and previously it's all been adults. I don't know, children strike me with fear generally. I guess. Just no, God, children. I think they're different, aren't they? They're small and different. So I think
fragile.
Yes, exactly. And I think in many ways there's so much a more pressing need to understand childhood epilepsies as well. I mean, and again, that gets complicated when you start to interact with the developmental trajectory and the types of brain changes that are ongoing. That, you know, it gets even more complicated. So I think we're hoping to have that focus group and just talk to some parents, talk to some children, especially around these issues that we think are there around sleep. What is their experience? Is it something that resonates, or is it something where, you know, we're thinking, because you look at the literature and you look at the small number of people, I guess, that we're talking to, and then sleep does seem to be an issue. Is it a broader issue? Is it something that really resonates with people who are experiencing living with epilepsy, living with a child with epilepsy? Do they think that could be something where improvements could be made if we understood more about what was going on?
Yeah, it's like that thing that so many people say, and I think I mentioned, is that, or maybe I didn't, that a lot of us would rather just have better mental health and sleep. And I wouldn't mind having a seizure every day if it meant that my mental health was better. And that's simply put, and it's not the case for everyone, but that is how I feel. And I know lots of people who do think this the same way. So I think it's important things like that are expressed to you guys as well.
That was the place we started, essentially. There's some papers out there that have interviewed, you know, a decent sized cohort of people with epilepsy, and that has been a recurring theme. And I guess that was kind of where we started, and it makes sense, you know. You know, if because of your epilepsy, or even maybe it's not because of your epilepsy, but your sleep is so bad, and, you know, you're suffering from depression, then anyone can understand how much of an impact that would have. I mean, you know, take a night where you haven't slept well, or take a week, or take a month. You know, no, people normally don't have to go through those issues, but take a long period of time where your sleep has not been where you would like it to be, and you are going to feel terrible. And maybe that then is the thing we need to understand, so that maybe you can do something to help the sleep side of things, and maybe that will have a knock-on effect on the epilepsy. Maybe it won't. Maybe, you know, from the point of view of seizures, maybe it won't have an impact. I'd suspect it would, but if it sort of didn't have an impact on the seizures, but it did have an impact on general well-being and quality of life and mental health aspects, that would be such a huge benefit to people.
Oh, huge. And that's why I think we need a closer link between those, like yourself, neurologists and neuropsychiatrists.
Yes.
Really much, because I was lucky enough recently to say to my neurologist, look, dude, if I can't get enough sleep, I anticipate I'm going to have a seizure, a bad tonic-clonic soon. Please, can you help me? But I was lucky. I was in London at UCL, and lucky that I could articulate that with a certain amount of confidence, and loads of people can't. So that's why I think there really should be a closer automatic link where people can say, do you know, possibly with you saying, by the way, dude, real close link here, they need to see the neuropsych or a sleep disorder specialist just to check them over. And that, as expensive as that will be, it could mean fewer trips to A&E. It could be, you know, fewer admissions or required admissions to a psych hospital, all these different things. So, yeah, but as you were saying, you know, communication is getting better between you all, which is great. So it's just that I think we need to work on that, right?
Definitely. So, I mean, we've started an epilepsy research network. I guess we've had it in Birmingham for probably 3 or 4 years now, and that is one of the main aims of that network is to make sure that anyone who has any passing interest in epilepsy, you know, so we have people from different clinical specialisms and sort of specialist nurses and psychiatrists and neurologists. We have people from the research end. We have had patient involvement as well, just to kind of give that sanity check of what we're doing and maybe help us to bring it together. But these disciplines need to be interacting more. And I think in many ways, epilepsy is kind of the perfect storm where it isn't going to be just under one specialism, because the impacts are so broad. And does your average psychiatrist know about epilepsy and about the interactions between epilepsy and sleep, say? Probably not. So And would your neurologist know about the mental health implications of living with epilepsy and the impact that poor sleep patterns might have on the susceptibility to that? Again, maybe not, but if we can bring people together and have those conversations and expose them to the different views coming from different directions, then hopefully that does have an impact. It does lead you to have a more rounded view of what epilepsy is and how it impacts on people's lives.
Yes. And let's go and say that to the government too. Dude,
yes.
It's not that simple. Funding. No. Yeah. Brilliant. Okay, cool. Thank you so much. You know what? We've gone on for like an hour and a quarter and we've yet to do our podcast. No, don't say sorry. This has been wonderful. I love it. I love it. And I hope that
put me down at some point. So when I was waffling on, you just say stop that.
No, you weren't waffling. Like you, oh, well, if you were, you could waffle all day as far as I'm concerned. And I'm sure that's the case for loads of people who are listening to this. So yes, so just so everybody knows, if you don't already, outrageous, but so the Epilepsy Sparks Insights podcast will be launched at the beginning of October. And so now Andy and I are going to record for the Insights podcast. So you'll be able to hear it on there as well. And we're also going to upload this video to YouTube. So if you know anybody who could be interested in this, please send them over to my YouTube page. Just type in my strangely spelt name, Torie Robinson. And you know what, if you can as well, get just people without epilepsy listening to this, because it is so interesting. And I think it encourages people to be less fearful of epilepsy and all the lovely stuff that goes with it, you know? So would you agree, Andy? Oh,
definitely. I mean, I think that's the thing, isn't it? I mean, everyone needs to know about epilepsy, really, don't they?
Everyone, yeah.
It has, not only does it have an impact on so many people, but it's a topic that really resonates with everyone. I mean, the kinds of issues that people are more susceptible to because they have epilepsy. It's not just about the epilepsy, is it? It's kind of, it's this broad thing, and there's so many people out there who know someone with epilepsy, but maybe don't know anything about epilepsy, and maybe are worried about asking and kind of prying. And, you know, if we can provide channels where the understanding can there, and people can ask questions, and it can become something that everyone is comfortable with.
Yeah, and there's no such thing as bad, or there shouldn't be such thing as a bad question, I don't think. And that goes not just for people affected by epilepsy, but also professionals such as yourself and medical professionals, because the best people will say, if they don't know the answer, do you know, I don't know the answer, but I'll find out. Or, do you know, this is the person you need to speak to. People that say they know everything, I don't trust them, you know. Those are the people to be aware of, I think. But no, this has been flipping brilliant, and I might have to nab you for another one, because we totally could go on for a longer time with this. So thank you so much, Andy, and I will email you in a second. If you want a break, maybe. All right, cool. Speak to you later. Bye.
Nice to see you. Thank you.
Bye-bye. Bye-bye.